So we'll move on with our next agenda. We have the administration for community living. We have Allison Burkhoff, Steve Hagee, and Cynthia LeCount, one of my heroes.
Good morning, greetings everyone. Hello Andy, good to see you as always. Our acting administrator, Allison Barkoff, who is also the acting assistant secretary on aging, was not able to make it this morning. So I'm here in her absence with our Director of Budget and Finance, Mr. Steve Hagee. And Steve has been with us for a really long time. I think 39 years or something at his post, but here for a really long time. It's good to be here. Hello, President Parton. Good to see you. Thank you for this coming out here and listening to us. And as we talk about the Administration for Community Living and the work that we do across the country, but primarily my focus, of course, is with tribal programs. I'm Cynthia LeCount. I'm Turtle Mountain Band of Chippewa. Grew up in Montana. I've been working with Title VI programs, with tribal aging programs since 1976. I know I don't look a day older than 40. You're all shocked. But and came to the federal government 13 years ago, joining the Administration on Aging. I'm going to talk overall a minute about the Administration for Community Living, which was formed in 2014, 2012. We merged with many of the disabilities programs across the government, primarily in HHS, but across the government, and merged with Administration on Aging, with the thought that while we're aging, we're living with disabilities, there's an intersection where we very easily coordinate, and that is in our desire to remain in our communities, living in our own homes, in our own communities. So overall, that's the mission of the Administration for Community Living, is just that, to keep our people in our communities and in their homes, rather than have to parcel them out to off-reservation or out-of-area assistance, which is so often the case with our limited number of nursing homes and other places of assistance for even our younger people with disabilities. So we have several arms across the Administration for Community Living. We have disabilities programs where we administer programs like the Centers for Independent Living, which are state programs scattered around. We have some protection and advocacy centers. We have one in the Four Corners area that primarily serves Navajo Nation and other tribes in that Four Corner area. That's our P&A center specific for tribes. We also have a research arm of Administration for Disabilities, and we're not the kind of guys that dons our white coats and goes into a research lab. We're sort of the guys that look at how day-to-day adaptations can be made in homes or in communities to enable continued living again. And look, my favorite example is always the doorknobs, rather than having one that turns, having one that you can move up and down or open in another way for people with limited abilities as far as movement. We also do some work around disabilities. We have 4 disability resource centers. One is the Christopher Reeves Foundation that you're probably most familiar with. And I really encourage you to look at Christopher Reeves Foundation and the many offerings it has for people who need adaptive equipment or who need other assistance. We also have the National Reese Center on Limb Loss that is just that. It can also help it with acquiring limbs and other assistance, and think again of our many people with diabetes or with other who have suffered some kind of accident in Indian country. We also have one on hearing. We work with deafness. We work with blindness. We work with pretty much all types of disabilities throughout our offices. So really check in as Steve's talking about our disabilities programs, where they are and what they are and how they can work with you in Indian country. On our aging side of the building, or our offices, our administration on aging works with and I forgot to mention that the disability programs, of course, were mainly born out of the Disabilities Act. On the other side of the fence, we have our Office on Aging and responding to the Older Americans Act. The Older Americans Act provides many services, again, usually for persons 60 years of age and older, again, to keep them in your communities and in their homes. All of our programs work collaboratively with one another. We always estimate that when we provide, I think it's $1 of federal funds, we're sort of bringing in an additional $9 to that person for services. So our dollars are collaborative dollars where we really need to coordinate with other agencies. Our Title VI programs, which are under my office, are the Title VI of the Older Americans Act, providing assistance to American Indian elders 60 years of age and older. We fund 60 years of age and older. You may have decided once the funds reach your community, your reservation, that you're going to lower that age. And we have tribes, I think our lowest age is 52 right now. We have quite a bit, 57 and 55. Again, the funds are given 60 and over. We're just funding, I think on Friday we get to push the magic button to fund our new Title VI grants that take us from this year through early, through early 2026. We have moved up from 282 grants in that program. We had 2 tribes who did not reapply, and now we are serving 292 Title VI programs, 1 in Hawaii, the rest in Alaska and the lower 48. Those programs we know are severely underfunded, but each year we seem to get out a little bit more dollars and find a new method of coordination that we can work with on our Title VI programs. We also have Title III programs under the Older Americans Act. Those grants go primarily to states. However, when state coffers or state funds are given, they're given based on population. So your tribal elders are also eligible for all Title III services managed through the state. We do, like I said, we do a lot of coordination out of our office. I know our programs rely heavily on the assistance from Indian Health with our CHRs and our fitness programs to enable exercise and movement in our the services that we provide. Transportation, huge transportation needs, and I know you're all aware of that, but that's also our concern, transporting those elders. And we are also looking at other sources of payment that you may be able to retrieve, such as billing state 1915C waivers for home and community-based services that you're providing to your Medicaid recipients. Many of those services we're already providing under Title VI. HUD is another area we rely heavily on. During COVID, we had so many needs identified from your programs and from your elders. We had holes in roofs, we had sewers that weren't working, we had water systems that weren't working, we had holes in floors, we knew we needed to build new ramps. We had so many home repairs and home assistance needs that come up because we were isolating our seniors in their homes. And so that forced us to take a harder look. Good morning, Chairman. That forces us to take a harder look at those homes and what resources we can find to repair them. We can use Title VI funds, but Title VI funds, I always caution, are the only funds that we can use to feed our elders, to provide nutritional meals. So anything we take those funds for, any other use of those funds could mean that we're not able to feed our elders. With that, I will be quiet and let my partner here go ahead with our money, money, money.
Thank you. I appreciate the opportunity to be here to speak with you, but much more importantly, to hear from you. I've been to a number of these over the years, and I'll note that the timing on this one is absolutely spot on. We got our guidance to begin our FY 2025 process for formulating our request that will go to the Secretary and then ultimately to OMB and the Congress. So we are right at the beginning. The feedback that you're giving us today will allow us to go back and incorporate that directly into the kinds of requests that we're going to be making. So in just a moment, I'm going to sit back, as Cynthia has done, and listen, because I want to take away information at this point in time. I do think it's important to give you a couple of the highlights of the 24 budget. A budget is nothing more than a statement of priorities, and the budget that was just released in March for this coming fiscal year contains a 64% increase overall for our Native American programs. It almost doubles the funding from just over $38 million to $70.2 million for our Native American nutrition and supportive services, our Title VI programs that Cynthia was referencing, and provides a 25% increase for caregiver supports. It more than doubles the funding for adult protective services. This is a new program that was first funded under COVID, or in the middle of COVID, with supplemental dollars. For the first time, Congress has put in ongoing funding in our annual appropriation in this year, and we are seeking to double that. One of the actions that we were successful in getting Congress to include was a set-aside for tribes that ensures that part of that money is going to our tribal programs. We'll be maintaining funding at $700,000 for 4 Native American resource centers, which we have funded on an ongoing basis for some time, and continuing funding under both our Medicare Improvements for Patients and Providers Act, which help various populations to lower their health care costs by finding other programs that they can be signed up for. And our protection and advocacy programs, where again we have a small increase, which allows us to provide legal representation and assistance to people with disabilities, both those that are living in the community and those that are in institutions. With that said, again, I'd like to sit back and just listen and take your comments back to our Assistant Secretary to be able to incorporate that as we move forward for the coming year. Thank you.
President Terry Parton.
Good morning. My name is Terry Parton, President for the Wichita Affiliated Tribes in Oklahoma. I just, during our last STAC meeting, I mentioned that, we always hear that elders are very important within our communities and we want to take care of them and stuff, but we don't see advocation for the budget. And so I just wanted to bring that up. Yesterday I was talking about dementia and autism, and everybody was referring me to the communities of living, and I don't see that you have the funding that you need available. The amounts provided for tribal programs at ACL are small but extremely vital to elder care in our communities. Resources for elder care from IHS are limited, and the services provided are largely covered by Medicaid or Medicare. This means that fees for services provide revenue to partially offset underfunding of IHS, but it doesn't really establish elder care programs, facilities, and institutions, particularly when services are provided outside of the four walls of a hospital or clinic. Our elders are our lifeblood to our communities, our tribal communities, and they help teach our kids and play important role models within our tribal communities. And so it's very important that we make sure that they are taken care of. So when Congress doesn't adequately fund elder care, we do whatever we can to provide that for our people. And like I mentioned during STAC, we don't often hear people advocating for that. It's just because with the elder programs, we just automatically supplement them. And so we want to make sure that we are advocating for more funding for those programs. The ACL resources for nutrition programs and caregiver support are extremely flexible and useful, but severely underfunded, particularly considering the authorized but unfunded provisions for elder care in the Indian Health Care Improvement Act. The President's budget proposed to nearly double the investment into tribal line items at ACL and to make permanent the newly established tribal set-aside of adult protective services funding, which you mentioned. We're greatly appreciative of this effort, but I am here today to urge HHS that we need more resources for care in our communities. And I just, during our last STAC meeting, I was texting one of our director for our Administration on Aging program, and our tribe only receives a little over $100,000 to fund, and as I explained then, a director, 2 cooks, a driver, provide transportation for our elders, and then the food for a whole year. So $100,000, that is not enough, and we supplement that. And again, that's our elders. We take care of them, but we need to advocate for more funding for those programs. And like I said yesterday, whenever I was asking about dementia, everybody kept directing me to the communities of living. So I want to bring that up as dementia has become something that's really prevalent within our tribe more recently. As many as 1 in 3 American Indians and Alaska Native people aged 65 and older will develop dementia in their lives. A 5-fold increase in cases among American Indians and Alaska Native people are projected from 2015 to 2060. And as many as 6 in 10 older American Indian and Alaska Natives with probable dementia remain either undiagnosed or are unaware of their diagnosis. And I want to give you a little story about one of my employees. Her dad, last year, they were trying to get him diagnosed with dementia. They knew he had it. He would give signs, but every time they took him to the doctor, there was nothing wrong with him. So they wouldn't keep him. They took him to IHS. They took him to a couple of other places, and nobody would diagnose him. They were finally told to leave him. A social worker told him to take him to the VA, leave him there, and tell him they couldn't care for him. And that's what they had to do to get him diagnosed. That was the only way they could get him diagnosed and put somewhere. And so I don't know what you guys can do to help advocate to do more. I don't know if it's more. I really don't know what the answer is to do that, but they have to be diagnosed more earlier so that they can get the services that they need. And we know that ACL is just one part of a much bigger picture of health and wellness for elders and community, but I'm here to emphasize that these programs are impactful and increased funding can go a long way. Thank you.
Thank you, President Parton.
Chief Bill?
Chief Bill here. And like I said, my name is Chief Bill. I'm the chairman and Alaska Area Representative of the National Health Board. As a Vietnam vet, war veteran and a retired Army Sergeant, I'm proud to have served my country and continue public service by serving tribal nations through the National Health Board. ACL provides resources for elder care, nutrition, and caregiver support that are vital to tribal health care because elder care and long-term services are vitally underfunded by the Indian Health Service, even though they are authorized in the Indian Health Care Improvement Act. And just this morning, I just heard that our President Biden signed in another executive order, action expanding access to child and elder care. And he didn't say he had the funds for it, he just did an executive order.
I watched that.
The resources are extremely flexible and useful, but severely limited to the amount at just $53 million for fiscal year 2023. The President budget calls for nearly doubling the resources for these programs, and National Health Board supports the continuous increase for elder care in the 2025 budget. The 2023 ombudsman also included a 5% tribal set-asides from funds for Adult Protection Service. Consistent with the National Health Board Resolution 2210, calls for an HHS wide 10% set aside for tribes. We urge ACL to propose that the tribal set asides be increased from 5 to 10%. Last, we need self-government expansion through the HHS. We need to maximize federal investments in outcome and not just paperwork and jobs for the people that run the programs. We also need to ensure power to provide culture, competent care for our people in our own way. Awata, thank you.
Thank you, Chief Bill.
Jennifer?
Good morning.
Good morning, Jennifer.
Jenny Webster from Oneida Nation and also representing Bemidji area. Tribal nations have struggled to receive adequate funding for our elder programs. Many ACL programs, such as congregate meal programs, are important for our community in maintaining connection with our elders. This program is one of the oldest and most widely supported for maintaining social ability and quality of life for tribal elders. For Oneida Nation, our Title VI grant covers only 6% of the overall budget for our Aging and Disability Services program. In fact, it doesn't cover even half the cost of operating our elder meal program. It's just one of the many elder programs that we provide. This means we're forced to find over $1 million each year from our own tribal dollars or other grants to help keep our elder programs up and running. We are also unable to expand our supportive services to our elders. In addition, the cost of recruiting and retaining personnel continues to rise, meaning it costs more just to maintain the same level of services. Our request, tribes need more funding from ACL, and ACL must ensure equitable funding is set aside for tribes, especially to staff our programs. We also believe that Title VI funding from ACL should be included in the expansion of self-governance within HHS, providing greater flexibility and reducing administrative burdens for tribes. Yawanko, thank you.
Thank you, Jennifer.
Nate?
Appreciate that, Councilman Joseph. Nate Tyler, Makah Tribe, Washington State. Here to support what the last two speakers spoke about. Specifically for Makah, though, we all know we don't have the resources. Very few tribes have the resources available. And we are sending quite a few members off res. And for us, it's 2 hours minimum. But we do also send members to Yakima, which is about an 8-hour trip for us. for long-term care, any of the services that they need. So on the Olympic Peninsula, we are really, really short on all these services. I know some tribes do have put services in place, and I think it's important to note that anytime the state does get money, that there should be consultation on that funding with tribes if the intent is for tribes. So, but I just wanted to throw that pitch in on supporting Chief Bill and Jennifer on what they spoke to.
Thank you, sir.
Councilman Arnold?
Yeah, if I could just add to what my colleague Councilman Tyler said, one of our goals in Nia Bay is a long-term care facility. We have, I can think of probably at least 18 in Port Angeles. 18 that are off-res? There are a lot, and so when you're isolated like that, it's tough. You don't get as many visitors because it's that's a 4-hour trip from someone from the reservation both ways, and and I think it would just be a benefit to the community to keep elders so they can age in place and they can stay within the community and connected. I think one of the ways that that we could be helped out with some of this is if we could include indirect rates and funding formulas as eligible costs, so that would help reduce shortfalls. I think we had an issue with Head Start and a budget shortfall. That's largely due to the circumstances of the past 3 years, but that might be some way to help kind of lessen the burden on the funding side of things. So anyway, thank you.
Thank you.
Chairman Ron Allen is in the house.
Whoa.
Thanks, Andy. I appreciate what ACL has been doing over the years, trying to help tribes address the fact that that we have aging community, and like America, quite frankly. So in many, if not most of our communities, the elders are over 50% of the community. And so it becomes a bigger challenge for the tribes in terms of resources. One of the things that, in terms of budgetary priorities and needs, is the resources to help plan and design facilities that would fit the tribal communities. Many of us have to conduct surveys to assess, what kind of services does our elders want. Is it independent living? Is it assisted living? Is it 24/7 needs, et cetera? So we have to have a decent profile of what those needs are so that we can plan and identify how we address those rising needs that are becoming more and more urgent in our communities. So I would advocate that Administrator, start inserting into the budget resources that tribes can access. I'd rather they be able to be direct, the way Jennifer noted, in self-governance, working that kind of an angle. But grant options seem to be the only vehicle that you have at the moment. At least it's an option to access resources. So I appreciate the summits, in terms of sharing best practices. Different tribes are tackling the need differently. The need for keeping elders active, which means keeping them healthy, is a big issue. And having access to nurses that can be dedicated for the facilities to make sure that they're doing well, whether they're testing their blood pressure or sugar count and what have you. So those are all important features or services that need to be inserted into whatever operations that we establish, whether it's a facility or a program. So it's something I think that is urgently needed, and so I would encourage that ACL take a hard look at that and try to insert that into a budget to start providing those kinds of services. Large and small, we all have the same need. So It's different from Alaska than Navajo and different Seminole and the Passamaquoddy up in Maine. We're all different, and we have different circumstances, different needs. But what we do have in common is we have a rising elder population. Thanks.
Thank you, sir.
Yeah, I have to say something. I always do for my elders, and Ron is right about the increase in population. 20 years ago, in the years kind of following, I always try to make a home for when our tribe hosts our big elder dinner, where we invite the tribes from the area to come there, and in our community center is packed. Well, when COVID hit and we was able to have our first elder dinner, we didn't want to. We was afraid to invite the neighboring tribes of the elders, and because we didn't want to possibly, share any sickness that we might have had, or vice versa. But the elders came from our reservation, from our tribe itself, our 12 tribes itself, and there was hardly a place to sit. The population with the baby boomers is real. And I physically seen that there's a lot of elders. The sad thing is a lot of our elders are watching over their children and grandchildren. The opioid crisis and fentanyl and stuff like that is real. A lot of our elders are taking care of those children now because their parents aren't really able to take care of their own children, and so that is an added expense for our elders. Costs of everything have gone up. Fuel, chickens, eggs, whatever you have to buy to. When I go to and I go have to travel quite a ways to go to a Walmart to do my grocery shop, and what used to cost maybe $200 to feed my family is now coming to around $600. So the impact to our elders that are put on the fixed income is I don't know how they're surviving. I was thinking about possibly retiring, but at the rate I would do it, I would probably be not really able to keep up with the way that we are used to living. So it'd probably be like my dad, working till he's in his mid-70s or older, and anyway, I just need to state that. Gil?
Thank you, Andy. Good morning,
Good
Cynthia.
morning, sir.
Buju Ani.
Good to see you.
This is coming directly from my elders, and that is the menu. With other program, we ask for flexibility, and I'm asking flexibility here because our seniors are always complaining about the portions of the food, about the quality of food, and I understand you have to stay with standard portion to provide and the nutritious meals we're supposed to provide. But sometimes they say it's not enough, it's not nutritious, or it's just not enough of what they're asking for. So maybe allowing us more flexibility to give them a little bit bigger portion of those that want it. Not everybody asks for that, but a lot of them do ask for a bigger portion or and then the variety of food that we provide them. Maybe include some more traditional foods in the menu so that we can have more traditional meals for them. So that's my request from our elders.
Thank you. I know I remember that portion control stuff. I'm a farmer's daughter from Montana, and they said your meat was supposed to be this size. Yeah.
Looking at the time, we're actually right on time for, and now, Cynthia, go ahead.
Can I make one comment,
Yes.
please, in response to both President Pardon, your comments about diagnoses? I'm going to talk with the Banner Alzheimer's Institute, which is actually located out of Phoenix, and some of you are familiar with that. I'm going to talk to them about the path of, after diagnoses, then what? And I'll get back to you on that one, but that's one of my projects. Chairman Allen, I also wanted to mention, a few years ago, we worked with Kitty and some other folks, Dr. Bruce Fink from IHS and some other folks about a resource center. We wanted to develop a long-term services and supports resource center for tribes. That resource center, based on recommendations from you folks and at STAC, that resource center was going to take the LTSS roadmap that's on the CMS website, and it was going to walk tribes through one at a time. You might recall that. We were going to walk tribes through this process, and I said we would be done working with the tribe when we could buy them a pretty gold shovel and put a red bow on it, and we can dig a hole and build a facility or do what we need to build. That was 4 years ago, I believe, and it failed miserably. So we are, I'm kissing my wounds and pulling that back together again. We will be advertising that resource center again. I think we'll advertise in June with another startup date in October. So keep posted on that, because we're working on that. And I knew it would be a slow process. I knew this resource center, that we wouldn't build 250 nursing homes or assisted livings in a year. But we might build 2 or 3, or we might help 2 or 3 tribes that then we could replicate and move on from there. So that's still my dream, and hopefully it's still Kitty's dream too, that we can coordinate and get this done. So stay tuned, everybody, for an announcement at the September STAC meeting that I hear will be in the Great Plains area.
Chief Bill.
Chief Bill here again. When we talk about nutrition food that we were just talking about, I'll give you an example in my little state of Alaska. My mother, when she was around, she wanted her native food, and one of the native foods is seagull eggs, and she can get it from the program for one egg a year. So as us kids, we go out and gather these seagull eggs, and there's a specific way to doing it. Like you can get one with 1 egg in a nest. It's good. It's just like a chicken egg. But Mom also wanted crunchy eggs. So when you find one with 4 eggs in it, there's going to be a little chicken in there. And they can preserve it and have it in the wintertime. I never knew my mom actually put them in an ice tray and froze them and ate them in the winter. But when we talk about nutrition and trying to feed our elders, we need to go back and look at our native food. My state of Alaska, our tribes say the table is set when the tide is out. You ever heard that statement?
Yep.
Everything from the sea lion to deals to eating the food. That's what a lot of the natives live on the deal. So it's the type of food that the elders need too. So when you think about these programs, and just like when I had my mom's potlatch, you can get a moose or caribou for a potlatch, but you can't get seafood in the state of Alaska. I told them to arrest me. I'm going to go out and get some shrimp from my mom. They gave me a special permit because they didn't want to arrest me, because they didn't want to go to court, just like they tried to do on the seagull eggs when an elder wanted to pick the eggs up off the airstrip, So native food, traditional food is where the nutrition is for our elders. Oh, I have to thank you.
Thank you.
Yeah, I really agree with that. I need to have the crabs and oysters and clams from my coastal relatives, as I really love that kind of food. But anyway, I was a relocation baby and raised by Port Gamble, Sklallam, and so those clam bakes had all that good food in it, and so it's, to me, my traditional food. We have to. I want to thank you, Cynthia, and Steve, for your presentation. We're going to move on with our agenda to the Centers for Medicare and Medicaid Services. So you're up next, Megan and Sally, I believe. So, Kitty Marks, she's another one of my champions, I believe, that's helped us for so many years. So thank you.
Good morning, everyone. I'm Megan Worstel. I'm the Chief Financial Officer at CMS. I'm excited to be here today because I actually have been here a couple times, but in the past years with COVID, I haven't gotten to see people in person, and it's nice to do that from time to time. In listening to the last presentation and hearing what you have to say, we, just like everybody else, it's been a difficult year this year, actually putting together our budget and our operating plan. I feel it when I go to the grocery store. It costs me 3 times as much money as it did 3 years ago. And when 6 to 8% inflation is pretty hard on everybody. So I look forward to hearing from you all and understand what everybody's going through, because I think it's been tough times for sure. As you all know, we are CMS oversees the largest federal health care programs, Medicare, Medicaid. We also do CHIP and the exchanges. The Division of Tribal Affairs that Kitty over here oversees is in our Centers for Medicaid and CHIP Services, CMCS, and receives the majority of the funding from program management. It's actually in our program operations account and in our federal admin account. And I say those because that is the area this year that we actually sent out our operating plan 3 months later than we usually do this year, because we couldn't even get through it with the amount of requests that we had and things like that. It was definitely a tough year. We also, Kitty's area also gets some funding from state grants and demonstrations account, which isn't where the real tough choices had to be made. For 23, they received $4.3 million, which was the same level that we requested in 24. I will tell you, I think we all wish that we could get more money, but to be in the flatlined area is actually a good thing these days based on what we've had to do in other areas. The funding is used to support outreach and education activities to encourage enrollment of the American Indian and Alaskan Natives in Medicare, Medicaid, and CHIP and the exchanges, training for IHS, tribal and urban Indian Health Business Office and patient record staff on Medicare, Medicaid, and other federal programs, and training for staff on billing and coding. The funding also supports research and analysis on data, strategic plan, regulations, tribal consultation, and outreach and education through a cooperative agreement with the National Indian Health Board. In addition to the funding that Kitty's area receives, CMS leverages existing agency outreach programs and support enrollment assistance of AI and ANs in Medicaid, CHIP, and the exchange program. At this time, I'm going to turn it over to Kitty, who's going to walk you through some of the programmatic details. Kitty?
Thank you, Megan. It's good to see you. I think it's been a couple years since I've seen you in person as well. So, good morning. I am Kitty Marks, the Director of the Division of Tribal Affairs. And in addition to the funding that we receive on the Fed admin side, the Division of Tribal Affairs has 8 full-time employees in our division. Plus, we work closely with 5 CMS Native American contacts located in the region. So we have 13 staff at CMS that are the Indian health subject matter experts across the agency. And so we're there to provide input into policy development around Medicare and Medicaid issues that might have tribal implications. And we're also there to provide technical assistance and, as Megan referred to, outreach and education. And so we know that the Medicare, Medicaid, and CHIP and marketplace revenues that come to the IHS tribal and urban facilities are critical to help support your programs. And so a lot of our work is encouraging American Indians, Alaska Natives to enroll in CMS programs that they are eligible for. So to that end, I'm excited to announce that on March 30th, CMS announced Connecting Kids to Coverage, Healthy Kids, American Indian, Alaska Native Outreach and Enrollment Cooperative Agreement grantees. And so this program under the Children's Health Insurance Program provides grant funding to eligible entities that include the Indian Health Service, tribes and tribal organizations, and urban Indian organizations. So this is a set-aside that is found in the Children's Health Insurance Program Act specifically for ITUs. And this award in 2023 is the 5th cycle of award that has been made to ITUs since 2010. So CMS was able to award $5.9 million to 7 tribal and urban Indian health programs in 6 states. All Nations Health Center in Montana, the Chickasaw Nation, Choctaw Nation of Oklahoma, the Denver Indian Health and Family Services Program, Fallon Paiute Shoshone Tribe in Nevada, Indian Health Board of Minneapolis, and Indian Health Council in California. And so the purpose of these grants are to help ITUs in those programs and states to, again, reach out to families and children who are eligible for Medicaid or CHIP but are not enrolled. And so a lot of the work will be doing outreach and education, identifying individuals, family, and children that are potentially eligible, and then helping this year in particular with the Medicaid unwinding renewal process that I'll talk about a little bit. So these grantees will be partnering with schools and other programs to reach young people, helping out with the application assistance process, using social media to conduct virtual outreach and enrollment. A lot of lessons were learned about virtual outreach and enrollment during the COVID, and then using parents and other community leaders to help with the enrollment process. The other issue I'd like to talk about, and I think many of you are familiar with this, is that during the public health emergency, Medicaid individuals enrolled in Medicaid continued to be enrolled in Medicaid. Basically, there was a waiver to allow continuous enrollment of Medicaid beneficiaries during the PHE. The Congress enacted the Consolidated Appropriations Act, allowing states beginning April 1st to start the general renewal process. And so states have begun making Medicaid and CHIP renewal determinations, sending out information to individuals currently enrolled in Medicaid, and for those individuals who are no longer eligible for Medicaid, we'll be sending out termination letters. And so states have from about 12 to 14 months to conduct this process, and states are vary as to when they will start this renewal process. Our office, along with the National Indian Health Board and the TTAG, have conducted outreach to ITUs at the local service level to let them know that individuals will be receiving renewal letters, and encouraging Medicaid patients to make sure that their contact information with the Medicaid agency is accurate, because the states have to send out renewal letters if they need additional information, and if that renewal letter is not received and the state tries again to reach out to the Medicaid individuals and no response is made, the states can terminate that individual. And so we don't want to lose individuals who are potentially eligible for Medicaid because they did not receive that renewal letter. And we know that postal delivery in some parts of Indian country are challenging. States have the opportunity to text and email Medicaid beneficiaries as well, but we know that broadband can be challenging as well. So we are working with the ITUs to help us get the word out. They're a trusted resource, and we want to reach out to all of you as well to help us be aware of the Medicaid unwinding process, to encourage tribal members to make sure that their Medicaid contact information is up to date. If they need assistance, go to their local Indian healthcare provider and say, hey, I received this renewal letter. What do I do with it? Because the beneficiaries have to return that within 30 days, or a whole nother process of either termination is going to happen. But we also are encouraging on the state Medicaid side to engage with tribes, to work with Indian healthcare providers in those states. At the state tribal meetings, talk about the Medicaid unwinding plans that the states have in place. We are encouraging state Medicaid agencies to share data. This is renewal and enrollment data with Indian healthcare providers, and they're allowed to do that because they are Medicaid providers, and this is data sharing that's allowed because it's for the administration of the Medicaid program. To date, we have 7 states that have shared data, and what we are hearing through our CMS TTAG Unwinding Subcommittee is that this information is really critical because they know if they see a wrong address, they know how to get in touch with that person. They may see some information that's not accurate, and they can work with the state Medicaid agency as well to make sure that that person returns their renewal form, or if they're no longer eligible for Medicaid, transition them to a health insurance marketplace plan. And for those who became Medicare eligible during the PHE but did not sign up for Medicare because they had Medicaid continuous enrollment, Medicare is allowing a 6-month special enrollment period where individuals, as we begin this unwinding process, can enroll in Medicare without paying a late enrollment penalty. And we know that that's a critical issue for Medicare beneficiaries in Indian country. Speaking of the marketplace, we've seen a tremendous increase in enrollment in the health insurance marketplace. There was a 13% increase for the 2023 open enrollment period. That's an additional 1.8 million individuals that signed up for the marketplace. There are a lot of advanced premium tax credits that lower premium amounts where people can purchase marketplace plans for less than $10 a month. And so we're seeing an increase in the marketplace, and that includes a 3% increase for American Indian and Alaska Native consumers. So we're trying to improve access, maintain access through Medicaid, but transition to the marketplace and increase access to health insurance through the marketplace to reduce the national uninsured rate across the nation. We also know that health equity is an important issue that we've heard from the CMS TTAG, and health equity is one of the key pillars for our agency. The CMS TTAG Health Equity Subcommittee, along with the National Indian Health Board, has produced a report, Health Equity in Indian Country, and CMS is looking at that report now. Our health equity plan is a framework, and so with this information from the health equity report from the TTAG and NIHB, we're looking at it and making sure that those recommendations are incorporated into our health equity framework. So we are committed to ensuring that we address the inequities and eliminate health disparities in Indian country. And I think the NIHB TTAG Health Equity Report really provides some good guidelines and historic background that CMS leadership appreciates in developing and working on our health equity framework more. So I'm going to stop there and turn it over to Ron, I guess, for first comments. Thank you.
Thanks, Kitty, and Megan as well. I appreciate your updates on the plans for CMS as it carries out its responsibilities to Indian country, and it's without a doubt it's complicated. For the record, my name is Ron Allen. I am the chair for the Jamestown S'Klallam Tribe, located in western Washington State, and chair for the CMS TTAG, the Tribal Technical Advisory Committee, which in my opinion is a misnomer because we're not necessarily technical, even though many members of our advisory are very technical in their skills and knowledge and expertise. But many of us who are tribal chairs and political representatives of our respective nations, we know just enough to be dangerous when it comes to this matter. So Megan and Kitty raised a lot of issues. I do, as I proceed to talk about what I think are budget priorities for CMS as it addresses its area of responsibilities to the tribes, and I would underscore trust responsibilities to the tribes. I do want to do a shout out. Kitty has been doing a fabulous job since she's come on board many years ago as the director of the program that serves the tribes, and Stacy and Devin and those that are in the secretary's office continue to champion for us. And I see Ben here with IHS. Our partnership with IHS is critically important to be successful as we advance our agenda with CMS and the third-party revenue and being able to deal with Medicaid programs, Medicare programs, CHIP programs, and deal with the current environment that we have. To say the obvious to everybody, we all have gone through 3 years plus of challenging times with the COVID-19 pandemic, and it has been challenging for all of us. We're coming out of it trying to, quote unquote, reboot and assess where we are and what are our needs. I want to point out that as we move forward, Kitty referenced briefly, the resources, and Megan did as well, resources that are dedicated to help TTAG do its job. We always put together a 5-year plan. We identify our priorities with regard to how can we address Medicaid, Medicare, CHIP programs, and in terms of, how can we better collaborate? What are the needs? There have been a number of topics that have been addressed, from the four walls issues to the telehealth issues to the unwinding process that is unfolding today. And the challenge, quite frankly, and the resources necessary is how the 574 Indian nations and our regional organizations that assist us and collaborate with us, and our national organization led by Chief Bill and Stacy Bolin and their whole team, they do a fabulous job of helping us navigate through the complicated world of CMS. And, it's not just a matter of making sure that we receive the appropriate reimbursement, because we do know that it's very challenging for Indian country to be competitive to recruit doctors, nurses, administrators, practitioners, specialists, et cetera, or even have resources to build facilities in often very remote areas to accommodate our ability to serve our peoples. And it is challenging. So the budget has to reflect it. I appreciate the fact that CMS is probably one of the largest agencies that serves America. And when we talk about billions to the point of trillions, it's a big number that Indian country asks, how do we fit into that budgetary paradigm? And are we being treated fairly? I've always appreciated NIHB and our budget advisory team, led by Andy and others, that have identified what the true need is. And we know that when we look at the few billions that we do get against the need of 50 billion plus, and using the metrics of how you measure the welfare and the treatment of individuals that need health care in America, we're not doing well. And it's amazing that we're as successful as we are serving our respective communities. And so we have to figure out ways to bridge that gap. I will say that in the IHS side and over there in the interior, the BIA side, these 105L leasing approaches is helpful in terms of tribes who have resources, who can build their own facilities or leverage their own facilities. But many tribes that are out there, and I underscore many, they don't have those resources. They don't have that capacity to leverage the monies to be able to take advantage of the 105L opportunities to just build the facilities. Now, we have facilities, but we don't have people in them. We have to have people in them, and we have to have the resources. So it circles you back consistently with the reimbursement rates and the ability for us to be able to champion that with you. So on the one hand, you say we need the resources to make our clinics and hospitals and ambulatory care services be successful, but if we don't have the ability and the resources to be able to collaborate with CMS, that's your responsibility. It's a trust responsibility. So the way you reach out to NIHB and regional Indian assistant regional healthcare organizations, USAID has one, the Portland area Indian Health Board has one, and so those are vehicles that we can help the tribes push back with regard to when we look at these regulations. You think that we have a lot of resources to be able to evaluate these regulations, provide recommendations to our colleagues so that we give you the best advice so that the regulations are respectful and complementary of what the tribes need. That is not necessarily available, quite frankly. When we talk about unwinding and we look at the options that our citizens as states out there, many of them, pushing Indians off of the rolls and inserting conditions of which that is unreasonable for tribes to be eligible for Medicaid, it makes our situation worse. So it exacerbates the problem that Indian country has. That has a low quality of care measured by the backdrop of America with regard to health care in America. So those resources. So it's not just, the resources that Kitty needs for her staff and her ability to assist us, but it's when it gets right down to it, what kind of resources are actually made available to us, and that can help us do our job to engage with you with both Medicare and Medicaid. Telehealth let me back up. The experience that we learned through COVID is the recognition that telehealth works and it's more efficient. But when you administer it, it's not the same as inside the four walls. Now, it's not the same as the four walls issue, but it's not the same in terms of how you prepare and engage with your citizens out there, whether they're elders or whether they're just citizens that are in remote areas of our service area. And do they have computers? Do they have access? So telehealth includes by audio. We got to call them up and walk them through where they are, what their conditions are, what's going on, and that is a service. We have to have somebody. If I have a doctor or a nurse specialist and they're talking to one of our citizens, we need to get reimbursed for that. So we need CMS to collaborate with OMB to assure that the OMB circulars are structured in a way that assures that we can recover that third-party revenue so that we can become more and more successful to bridge the gap of where we are versus where we need to be in order to help our communities be healthy. We're following on the heels of elder care and elder needs, et cetera. Well, as you get older, you have more health care issues. And so they go together, quite frankly, and they're complementary, set aside all the other challenges that we have out there. We're well aware that opiate and substance abuse, fentanyl, heroin, meth, and all those dependency drugs, if you will, are causing rampant problems across America. But it's disproportionately, a phrase that Kitty pointed out, that it's disproportionate in our own communities. And so we need resources to be able to tackle those kinds of problems that are out there on top of your primary care or even specialty care, if you will. Outpatient treatment programs, inpatient crisis-centered programs, quite frankly, they're few and far between. And so we are wrestling with how to provide the kinds of environment that we need out in Indian country. So in our 5-year plan, we identify a lot of needs. I just want to make sure I want you to refresh that. I want you to rethinking it. And we have subgroups in our TTAG. Our TTAG are individuals who represent the 12 regions. That's helpful, but we also have other specialists who can collaborate with you and with you and Kitty and the administrator to talk about how we can rethink how you can carry out your trust responsibility, adjust budgets, provide more dedicated resources for tribes. So it's not, and all tribes, quite frankly. So Navajo will have a certain set of issues. Cherokee will have a different set of issues, even though they're both very large tribes. But then Chief Bill will talk about some of these small villages of the northern slope of Alaska, or I can go to Micmacs up in Maine. There's another small tribe, or my tribe in Washington State, and on down the line. We vary in size. And so the needs are still there, and it's a matter of how do we make adjustments to help us do it. Indian country is one creative world, and it's how we've been able to bridge what little we do receive, including the third party with CMS, which is critical, what we get from IHS and we get from other agencies, SAMHSA, et cetera. And our challenge is to try to piecemeal them together, if I can put it that way, to try to make them collaborative, to make the synergy of those multiple resources work together to the benefit of our community. So at the end of the day, we know you have a big challenge. CMS has a big challenge. Hundreds of millions of people, got it, but we have millions of indigenous people that have a unique relationship in America, and we are no longer accepting being an afterthought policy when it comes to budgetary priorities. So I'm sorry I drug on a little longer than I probably wanted to, and I'm sure that we will collaborate with NIHB on identifying specific kinds of budgetary recommendations for 23, 24, 25, and beyond, and trying to continue to bridge that gap. We do appreciate the fact that President Biden is making a significant commitment to Indian country, but we still have to deliver. He can put a proposal on the table, but Congress has to concur, and those are big steps, but we still have a long journey to go. And we want to keep it into perspective. The backdrop of Indian country need and CMS's role in that backdrop to fulfill that need is overwhelming. So I will stop there, Megan and Kitty, and Annie, thank you for the opportunity.
We have about 8 minutes. I have Claudia and Bill.
Zambechwa, Nananiha, Claudia Washki. Good morning. My name is Claudia Washki. I'm with the Shoshone-Bannock Tribes. I'm the secretary for the Fort Hall Business Council in Southeast Idaho. I want to thank Megan and Kitty, as well as Ron Allen, for giving our updates on CMS. I'd like to reiterate the importance of keeping a very close eye on the Medicaid unwinding period. In Idaho, Idaho is one of the first states to go ahead and go through this process of what we've been calling on the reservation of purging their rolls on Medicaid. The state of Idaho has determined that there's going to be about 150,000 people that they'll be removing from Medicaid. Of that, we estimate probably about 20,000 are going to be Native American individuals, adults and children. And our Native American population is at high risk of losing coverage once that redetermination starts. Letters were sent out. I know that for a fact because my grandson received one. I am now the caretaker of my grandson, my 20-month-old grandson. And I only found out about this program through our tribal liaison, our tribal health director, who is the one who told us about it. Indian Health Service did not give us any notification that his redetermination was coming up shortly. We request that CMS provides accurate oversight over the states when they're conducting their Medicaid redeterminations. Some tribes have encountered roadblocks when trying to coordinate with their states on successful redetermination for their tribal members, such as data collection, data request, outlining and planning, outreach, and understanding what will be needed for successful redetermination processes. It would be helpful for the state health departments to consider how divisions responsible for Medicaid and food assistance can work together when coordinating with tribes to facilitate as many tribal members to stay connected with services when possible. Additionally, many issues that tribes are facing with Medicaid unwinding are large-scale problems with redetermination and eligibility process. Our people should not be losing their health coverage because barriers on receiving physical mail on our reservations or having limited access to phones. We do have our barriers when it comes to having broadband coverage on our reservation as well. Those individuals who need to fill out those applications, whether they be the paper applications, they typically have to go in for services for that, whether it be through their state office or when they getting that assistance at IHS for someone to help them walk through that process. If they can navigate that on their own, if they have access to Wi-Fi, but a lot of times the majority of our households on the reservation do not have access to Wi-Fi. I know that CMS has been taking a look at improving prior authorization processes. Prior authorizations have been a significant barrier to receiving health care in the Northwest. Our providers receive claim denials for prior authorizations, and often for our patients, they have a delay access to specialty health care services and patient SUD treatments. It's a trust responsibility, and the services that we receive through health care services, those are designated for our people to receive those services that are much in need. We just want to ask that CMS support states and the tribes' request to exempt IHCPs from having to obtain prior authorization to receive life-saving health services. When negotiating standard terms and conditions for Idaho Behavioral Health Plan 1915B, the waiver for the past year, CMS has required the state of Idaho and Idaho tribes to remove language exempting IHCP and American Indian and Alaskan Natives from prior authorization requirements. This is concerning because this provision has been previously negotiated and agreed upon to be excluded in 2017. So some states have recently expanded Medicaid, which in turn has increased Medicaid enrollment for both tribal health programs. And that is what we want. We want our individuals to have that Medicaid enrollment so that they can receive those services. We ask and request that CMS continue to make available funding to tribes for Medicaid eligibility and enrollment assistance. Thank you.
Chief Will.
Thank you, Andy. Yeah, for the record, my name is Chief Bill. I am the chairman and Alaska Area Representative for the National Health Board. And as a Vietnam veteran and retired Army Sergeant, I'm proud to serve my country and to continue in public service by serving the tribal nations through the National Health Board. Medicare and Medicaid reimbursements are a vital source of funding for the Indian health programs. Together, they supplement the dramatic, inadequate direct funding from Indian Health Service to help fulfill the federal trust responsibility for Indian health. Congress authorized Indian health systems across the Medicaid programs to help address dramatic health and resources inadequate and to implement its trust and treaty responsibility to provide health care for the tribes and their citizens. However, the current status is not fulfillment those obligations equally through the Medicaid program because states have the options of selecting some or none of the option Medicaid services and reimbursements at various rates. Well, federal law exempts Indian Health Service beneficiaries from paying Medicaid, Medicaid premises, and other Medicaid cost sharing. There is no such exemptions for Medicare. Most elders cannot afford the standard premiums, and even those who could have little incentive to pay, given their rights to receive no charge care from the Indian Health Service. And a small example of that, my mom, Chief Marie Smith, was up in her 80s and 90s, and they kept on trying to get her to sign up for Medicaid, Medicare, and she said, I got an Indian Health Service, I don't need that. She didn't realize how inadequate the system was, but that's the educational part of it. As a result, Indian Health Service and tribal facilities are only being paid about 80 cents on the dollar for Medicare service compared to other providers. The CMS Tribal Technical Advisory Group, TTAC, has been very active in developing both legislation and administration solutions for these and other related issues. Instead of reading off all their great work and listening to what Ron had, we encourage you to stay engaged with the TTAC and include it as recommendations in the 2025 President's budget. Awata, thank you.
Okay, I believe we're at 11.
Andy, can I add something? I
Yes.
just appreciate everybody's remarks, and I took notes, and we'll follow through. But I want to let people know that Deputy Administrator John Blum will be at the NIHB conference, and CMS is holding a listening session where the Deputy Administrator will be there, and we have briefed him on the CMS TTAG priorities, and he will be making site visits to YK Hospital and other hospitals in Alaska, so he can appreciate the remoteness and various issues. So thank you very much. So
Thank you, Megan and Kitty, for all the work that you do. Just, I guess for the record, I always have to say it. In every one of my paychecks from when I was 14 years old on up to today, we pay in FICA. So I really believe that tribal members, people that are eligible, that are enrolled, shouldn't be exempt from having to pay for something that's already been promised to us. As Ron stated several times, it's a trust responsibility to provide the services to us. And so why are we paying you guys up front? And do we even get what we paid back? Also, when my elders become seniors and co-pays are there, they're I call it triple dipped, because the U.S. government's already double dipping on us by making us pay our part. That was designed for the average citizen of the United States. It wasn't designed for Native Americans to have to pay in to something that's been owed to us from the beginning. Just got to say that for the record. I think I've said it 20 years now, but anyway, just it bothers me when we have to pay and then we have to come here and ask for more services when it should be already given. But thank you for the work that you do. I know that might be something that tribes will have to take up on our own to figure out how we recover all that we've paid in over these years. Thank you. We'll move on to we have the Health Resources and Services Administration, and I believe I got a text here. We have Garrett DeVinny, Chief of Staff of the Administrator, is going to speak on that, and Elizabeth Duval. So the floor is yours.
Good morning. Thank you, Councilman Joseph, elected tribal officials, tribal leaders, and HHS colleagues. My name is Garrett DeVinny. I'm the Chief of Staff of the Health Resources and Services Administration, or HRSA. I'm pleased to be here with you in support of our shared goal to improve health outcomes in Indian Country. Carol Johnson, our HRSA administrator, is actually testifying in front of Congress as we speak, which is why she isn't able to be here today. I'm sure she'd much prefer to be in this seat than up there. However, she sends her regards and appreciation to all of you for your partnership with HRSA and dedication to ensuring your communities get access to quality healthcare services. I'm also happy to be joined by my colleague, Liz DeVos, HRSA's Chief Financial Officer. She's going to be providing an overview of HRSA's key budget requests and initiatives. But before I turn things over to Liz, I'd like to share a bit about HRSA and our priorities. HRSA is the agency within HHS that supports delivering healthcare in the nation's highest need communities, building the healthcare workforce, improving maternal and child health, and meeting the healthcare needs of individuals in rural areas. From supporting primary care service delivery to delivering financial relief for hospitals and providers on the front lines of the COVID-19 pandemic, HRSA programs reach millions of people at risk and in need, including families, pregnant women, infants, children, and adolescents, those living with HIV, and hard-to-reach populations. We accomplish the majority of this work through grant funds to organizations, local health departments, communities, and tribes. We're proud to have grantees across Indian Country. In fiscal year 2022, HRSA awarded $112 million to tribes and tribal organizations. Specifically, we funded 64 different tribes and tribal serving organizations through a total of 107 awards. But we know that our work does not stop there and that much more needs to be done. The President's FY 2024 budget has significant resources that build on investments for tribes and tribal serving organizations, which you'll hear more about from Liz in just a bit. But it's important for me to note that HRSA's partnership with tribal nations has never been more vital. We're committed to working closely and collaboratively with you to support you and the populations that you serve. And we acknowledge your priorities related to provider shortages, National Health Service Corps placements, set-aside funding, simplifying grant applications and the reporting process, as well as bettering health outcomes. We're absolutely dedicated to improving our efforts on all of these fronts, and I believe our shared interests offer real opportunities for collaboration. Before I turn it over to Liz to provide more specifics on the HRSA budget, I want to quickly share some information on 3 vital HRSA programs whose mandatory funding expires at the end of the current fiscal year. First, our Community Health Center program, which provides high-quality, cost-effective care to over 30 million people through 1,400 local health centers operating nearly 15,000 sites that see patients regardless of their ability to pay. Health centers are a vital source of care for individuals and families who are uninsured or underinsured, people who live in rural areas, folks enrolled in Medicaid, and others who find it hard to find a healthcare provider or pay for the cost of care. Currently, 35 of our health centers are also duly funded by the Indian Health Service. I also just wanted to make a note, given the conversation regarding Medicaid unwinding, that HRSA is very involved in efforts to address and limit the impact of these redetermination efforts that have already kicked off. We fully expect our health centers to face the brunt of folks that may get kicked off the Medicaid rolls. And as I mentioned, we're working very hard to try to limit that impact. We've released over $3 million to primary care associations to work with health centers to conduct outreach and make sure that patients know what is coming and that they're able to continue getting access to care. We're also planning to send a joint letter with CMS in the coming weeks clarifying uses of funds for our maternal and child health dollars to make sure that those populations are aware of these redetermination efforts that have already kicked off in some of the states. The second program that I wanted to make specific reference to was the National Health Service Corps program. This is the program where we provide scholarships and loan repayment to students and clinicians in return for them practicing in health professional shortage areas. Last year, at a time of critical health workforce challenges during the pandemic, we were able to reach a historic high of over 20,000 National Health Service Corps clinicians practicing in underserved and rural areas thanks to this program, as well as more than 3,000 medical students currently receiving scholarships in return for their service commitment to practice in high-needs community upon graduation. And thanks to the $15.6 million set aside from Congress for Indian Health Service providers, the National Health Service Corps was able to award loan repayment to all eligible providers to serve at Indian Health Service and other tribal health facilities. In 2022, there were nearly 1,200 National Health Service Corps clinicians serving in Indian country, and 575 of those clinicians provided mental health and behavioral health services at tribal sites. The third program I want to briefly touch on is the Teaching Health Center Graduate Medical Education Program, or THC-GME program. This program funds medical and dental residency programs in settings like health centers, recognizing that most of primary care takes place in these community-based settings, not the acute care hospitals. This fiscal year, we will have more than 1,100 primary care medical and dental residents training in these community settings, with recruitment of new residents for Match Day 2024 beginning as early as this fall. The THC-GME program awarded 2 tribal recipients in fiscal year 2022 with a total investment of nearly $3.7 million. Some of my colleagues were able to visit one of these awardees during HRSA's Tribal Advisory Council meeting last month in Oklahoma. It was exciting for them to see and hear firsthand how medical students are going to serve their community through the primary care training they're receiving at Oklahoma State University. And we were delighted to have the chance to meet with program directors and discuss the public health challenges on the ground and various opportunities going forward. And for the first time ever, thanks to the American Rescue Plan, we awarded planning and development grants to health centers and other qualified providers because we know how challenging it can be to start up these new residency programs. These planning grants are essentially created to provide the startup costs necessary to be able to build towards applying for the THC-GME program in the future. And we actually sent out 46 awards a few weeks ago to entities. The President's budget includes 3 years of mandatory funding for each of these 3 programs. This multi-year funding request will help us prevent disruptions in care or training for millions of patients and thousands of students and clinicians, while also giving health centers, medical residents, and students predictability and confidence in the sustainability of these programs as they grow. We look forward to working closely with Congress to sustain and build on the work of these 3 programs. Finally, we've heard your requests for increased assistance with securing grant funding opportunities. We recognize the administrative challenges you and others may face in applying for funding opportunities, and we've tried to work to address them. we've identified a few ways to simplify our application processes so existing and future applicants are better able to apply. For example, we're working to use more plain language and minimize burdensome application requirements. And we're committed to improving the clarity of our funding notices and expanding our outreach to a more diverse range of applicants. This includes routinely sharing opportunities with tribal leaders through regional networks and offering technical assistance during the application process. In fact, HRSA, we currently have a few funding opportunities that are open to tribes, and our tribal affairs team, who's here today, is happy to share these with you and get you connected with our respective regional offices for help in applying. I just want to thank you for the opportunity to join you today. I look forward to hearing about your priorities and recommendations. I'm going to turn it over to Liz to get into a little bit more of the specifics regarding the HRSA budget. Thank you.
Good morning. I am Liz DeVos, HRSA's Chief Financial Officer and Director of the Office of Budget and Finance. I'm pleased to be with you today, and I'm going to be providing you with an overview of HRSA's FY 2024 budget request, although I think Garrett may have stolen some of my thunder already on that piece. HRSA's total 2024 budget request totals $15.9 billion. This includes $9.2 billion from discretionary funds that we get from the appropriations committees and $6.6 billion in mandatory funds that come from the authorizing committees. So we have a lot of work on our plate. The request supports a number of HRSA priorities. I'm going to go into more detail about them, but I'll give you an overview at first. Our important work to grow, diversify, and promote the well-being of the health workforce, integrate behavioral health and primary care, reduce maternal mortality, invest in rural health, and expand equitable and quality access to health care services in communities that need it the most. That includes tribal communities and Indian country. So let's take a dive into the 2024 budget request. So the first priority I want to highlight is health workforce. As Garrett highlighted, the budget extends and increases mandatory funding for the National Service Corps and the Teaching Health Center Graduate Medical Education Program for 3 years through 2026. As you know, the National Service Corps provides scholarships and loan repayment to clinicians in return for practicing in underserved areas. The request will support over 20,000 providers, which is the high point we've just reached this past year with some of the pandemic relief funds. The Teaching Health Center Graduate Medical Education Program, with the 2024 budget request, will fund 1,400 primary care physicians and dental residents in community-based settings. This builds on the investments we made with our pandemic relief funds with both the development grants and to bring on new Teaching Health Center Graduate Medical Education programs. The next priority in terms of workforce in the budget is nursing. The budget includes a total of about $350 million to support nursing training and education, with new resources to train certified nurse midwives and other new resources to modernize nursing education programs by increasing nurse faculty, recognizing that in order to have new nurses, we need to have faculty to teach them. The budget also has a new initiative to seed new approaches with our new healthcare workforce innovation workforce program. And this is to help grow the healthcare workforce by looking for more innovative practices in sort of health workforce education. This is something that we've been talking to with a number of stakeholders and is a very new, exciting part of our budget. Finally, the budget expands the diversity of health professions workforce with an investment of $110 million. This is an increase of $10.7 million over the prior fiscal year. The second priority within our budget is behavioral health and expanding access to behavioral health care through integration of behavioral health in primary care settings. The big piece in our budget is that within the context of the health center funding, there's an investment to double behavioral health funding in health centers to support service expansion and require that all health centers provide mental health and substance use disorder services. There's also a significant increase in our behavioral health training programs. The total is $387 million to increase the number of behavioral health professionals in underserved community and provide resources to integrate mental health in community-based settings. With this request, we're looking to train 18,000 mental health and SUD providers and expand those community-based opportunities. Also in workforce, within the National Health Service Corps request, we're diving a little bit deeper here, there is a new proposal to invest $25 million to support loan repayment for mental health and behavioral health providers, including peer support specialists and crisis centers. And finally, the budget invests a total of $165 million through our Rural Community Opioid Response Program. That's an increase of $20 million to provide needed behavioral health, opioid use, and other substance use disorder services to rural residents. The third priority I'm going to speak to today is maternal health and maternal mortality. The budget requests $276 million in HRSA programs to work to reduce maternal mortality by investing in the social determinants of maternal health, increasing screening and treatment for maternal depression, increasing and diversifying the midwife and doula workforce, and expanding access to maternal care services. This has been a key focus of HRSA's for the past few years. We got some new resources last year in the 23 budget. This builds and expands on that. Next is rural health, a key priority within HRSA. HRSA is home of the Federal Office of Rural Health Policy, and the budget provides $416 million, an increase of $63 million over 23, to really strengthen our healthcare networks and systems within rural communities. There's 3 new programs in the budget that I'm excited to tell you about today. There's $10 million for emergency, targeted, and in-depth, high-quality technical assistance to rural hospitals severely at risk for imminent closure and struggling to maintain healthcare services. As a complementary effort, there's also $20 million for a new pilot program to support these at-risk rural hospitals in providing services that would help patients avoid having to bypass rural hospitals, so looking at ways to create new service lines within rural hospitals so patients go there instead of bypassing them and driving past them to go to hospitals that are further away that have those services. Finally, there's $10 million for a new pilot program to enable rural health clinics to bring critical behavioral and mental health services to rural areas where there are no other behavioral health services being provided. I feel like I've saved the best almost for last, which is expanding healthcare access. The budget proposes to double health center funding over 5 years with a critical down payment in FY 2024. And so we talked a little bit about the investment in behavioral health services. There's also, with these resources, we would also have a new access point competition. So new entities could apply to become a health center site. And there'd also be resources, if this budget is enacted, to expand health center service hours. There's also funds within the HRSA budget to continue our commitment to ending the HIV epidemic within health centers. That includes outreach and support to approximately 400 health centers and through our Ryan White Care Act program. That's $290 million to provide care and services to an estimated 76,000 people who prior to the start of this initiative were not in HIV care. The last item I will touch on is through our Office of the Advancement of Telehealth, and I heard you talking a little bit about telehealth in the prior meeting. HRSA is leading the use on telehealth technology for healthcare in hard-to-reach communities. The budget provides $44.5 million to increase access to healthcare through direct-to-consumer telehealth services. I want to close by reiterating the importance of tribal engagement in the formulation and implementation of HRSA's programs. I'm looking forward to continuing to listen in and learn more about your tribal priorities, and happy to answer any questions you have about the HRSA budget. I yield back to, I think, the chairman or yield back to the chair.
Okay, we have questions. Will and Chief Will.
Thank you. For the record, my name is Chief Bill. I'm the chairman and Alaska Area Representative for the National Health Board. And as a Vietnam vet and a retired Army Sergeant, I'm proud to have served my country and continue to serve it through public service, serving the tribal nationals through the National Health Board. HRSA provides resources for the tribal health centers, including Graduate Medical Education Center of Excellency, the National Health Service Corps, and various grants for rural health. These programs are all vital for tribal communities, yet have little penetration into Indian country. Tribes continue to report that the interactive with the HRSA, that staff lacks the knowledge of the Indian Health Service and how tribal nations provide complex and effective health care delivery services. Chasing after comprehensive grants, competed grants, is also a time-consuming complaint and ineffective, especially for small tribes, communities with small and overtaxed administration staff. HRSA must do a better understanding and funding tribal nations that should be done at the stages of NOFO development, outreach, and training. And then we called on HRSA to engage Indian country to significantly increase tribal access to your grant programs. Too often, tribal nations apply for HRSA grants but are ultimately not funded. Instead, HRSA must reserve the portion of the grants to tribal communities, ensure that funds are spread wisely. We request HRSA provide a 10% set aside for tribes. When that is not possible through the statutory authorities, please request that this be part of the 2025 budget request. I will go back. Thank you, Andy.
Go ahead, Councilman Arnold.
So it just occurred to me that I haven't been doing this, but I'm Rufus Arnold for the record, councilman from the Makah tribe. So out at Makah, our staff has been very vocal about the need for HRSA to have a tribal liaison. Our staff, as we talked about with a lot of grant reporting earlier, I'm not sure if you were all here for part of that conversation, but our staff talks a lot about how the grant reporting system and grant solutions is very cumbersome, and they wind up spending a lot of their grant hours paid for from the grant doing reporting rather than the actual work. So one of the suggestions from our staff in Makah would be a tribal liaison to help streamline this process and free up their time so that they can do actual work and not reporting. So that was the biggest concern from our staff. So that's pretty much what I got. So thank you for your time.
Yeah, if I could just respond quickly, really appreciate the comment. I think we share a similar goal. We obviously want our grantees' time to be spent carrying out the activities and serving the population. So totally here, we'll take that back as well as connect you with our tribal representatives in particular. Thanks.
Thank you.
Are there any other questions? I know HRSA works with my tribe. Two of our clinics are 638, and they're both really isolated. So they're the only healthcare facilities available for not only our tribal members but the general public. And HRSA's able to help out with our non-tribal patients. It's pretty strict how we can't mix any IHS funding with HRSA. And we have to really keep tight records to make sure that we're not spending any IHS funding on non-tribal. So. And we're following that. I am the president of the Healing Lodge of Seven Nations Youth Treatment Center, and we were going through our budget last week, and lately I've been seeing where we're bringing in patients that are non-tribal from the state that need treatment, and so I asked our executive team there to possibly pursue HRSA to see what we can bring in to help offset the funding, because we can't be spending IHS dollars on our those patients as well. So anyway, it's not an individual tribal program. The Healing Lodge is of 7 nations, is 7 separate tribes that pulled together, and we have our own board that oversees what's going on at the Healing Lodge. So I kind of wish I could have had a little more time with Kitty about talking about cross states, because we're bringing in patients from Montana, from Arizona, from Alaska, wherever, and there should be like an all-inclusive rate that helps cover the expenses. When we and also in my tribe we have a nursing home, and sometimes we have non-tribal patients. They're married. Some of our enrolled members are married, to non-tribals, and anyway, we have an inpatient encounter rate, and that's a good thing because it helps cover the expense. But there should be like an all-inclusive rate, because it costs the same to operate that facility whether you're tribal or non. And I imagine Alaska deals with the same issue because of their isolation. I know Macaw is really isolated, and they probably rely on HRSA, a lot. So somehow HRSA and IHS and CMS need to get together and look at the actual cost expense of operating facilities in some of these areas that are really rural, like Macaw and up in Alaska. The Alaska Native villages are, totally isolated. Well, when Susan Johnson from Region 10 came to Colville, she compared us to the Alaskan frontier as a hard-to-serve area. It's hard to get providers that come in to fill any position that's there for IHS, for tribes, or for the non-tribals that we serve with HRSA funding. So anyway, I just think that somehow we all need to work together to kind of streamline the process on how things can work. So, we can help each other. We 638'd our alcohol and mental health department years ago, and a couple of years back, my council, we authorized to treat the whole family. So that means, if a family has someone that's dealing with alcohol or drugs, and then we're going to treat all, try to cure the whole family, because if you don't treat them all, then somebody's probably going to relapse, and then you're starting all over again. In the long run, it will save money, down the road, versus having an elder have to take care of family or children, because of the different issues that happen in our families. So I just had to, so our tribal program, I believe, applied for HRSA as well to help with some of those non-beneficiaries. But like I said, it costs the same to treat everyone no matter where we're at, and it don't seem right if we get an encounter rate for our tribal members at more of what it actually costs, and then we have to go down to a lower rate to help cover the expense of the non-tribal beneficiaries. So it's almost like losing money, losing part of the expense. So somehow we got to figure that out. But did you have some more there?
I was just going to tag on to your statement there, since you talked about how isolated we are. I think we've had IHS providers come to Nia Bay, and they say it's really more like working in a remote Alaskan village. I was an EMT firefighter for 5 years out there, so the nearest hospital that we transport to is about 78 miles away from us. And so every time we would take someone to Port Angeles or even Forks, that's about 4 hours of our day, because it's about 2 hours there, 2 hours, maybe 3 hours back, depending on conditions. So, and that's highly dependent on the road, which the quality is tenuous at best. So, if I could just tag on to put in perspective how isolated we are in Nia Bay at Macaw. So, thank you.
You know, I know HRSA works on trying to recruit and retain. There's, I believe, a national shortage on doctors and nurses, and anyway, you come out to Indian country and IHS, what they pay for doctors and nurses don't really come close to what the competition is around us. The grass is greener on the other side of the fence. What's sad is we send our people to school to become doctors and nurses. They come to work for us for a week or two and find out from their friends that they could make twice as much across the river or out in a big city, you know, almost 3 times as much. A lot of them get signing bonuses, and they get their college tuition paid off as, come and work for me, I'll take care of you. So our people get left out, and anyways, we're going to have to renegotiate our encounter rate, because right now on our nursing home we're having to contract to bring in these nurses that are making, you know, they're making bank. So it's taken away from our tribe's ability to utilize some of the fundings that is supposed to help us build a new facility. And anyway, just it's getting to that point. But the encounter rate does help, and I encourage every tribe to look at, you know, that process of, if you want to have a nursing home. We had to go through our state legislators to have them authorize this new type of funding stream that wasn't normal to the states. And anyway, we did that, and it passed. One of the questions was, will you get the same rate for non-tribals if they stay in your facility? And I had to tell them, I don't think we'll be able to do that. But those patients will benefit from the the higher quality of care that we're able to provide with what we receive. And so that was as close as I could get. But somehow we need to work it out where there's an all-inclusive rate and also state, where states, their rate comes up to the same rate of pay, because some states they don't pay as high of a rate, and they're not eligible for it. But any other questions? Oh, I don't see any hands up, so and I believe we're actually quite a bit ahead schedule, so we could take an early lunch. I want to thank you both, Garrett and Elizabeth, for all that you do with HRSA and helping our tribes.
Thank you.
So we'll break for early lunch. We'll get started right at 1 o'clock.
Produced by the U.S. Department of Health and Human Services.